On today's episode of the Dr. Geo Prostate Podcast, Dr. Geo talks with Dr. Thomas Masterson, a top urologist from the University of Miami, known for his work in male infertility, sexual health, and testosterone therapy. They tackle a big question: can testosterone therapy harm your prostate? Together, they do a deep dive into the science of testosterone. Dr. Masterson clears up myths and shares insights from the groundbreaking Traverse trial. Tune in for a clear, evidence-based look at testosterone and prostate health and what it really means for you. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, where it is my pleasure and my passion to enlighten you, perhaps educate you, empower you to take control of your health, your prostate, and everything to do with men's health. Today, I have the great pleasure of speaking with Dr. Tom Masterson. Tom, thank you so much for being on. Such a pleasure, and I'm always grateful to the fact that people like you, who I know are very busy practice, University of Miami, are coming on, taking time from your day. I know your first child, I had texted you. I said, well, this is child number 3 here, isn't it? They know it's number 1. I was like, oh, number 1. All right. So you know, I'll send you a celebratory text when it's number 2 and 3, if I know about it. A congratulatory, that is. We met at one of the recent conferences, and you were part of a panel discussion. I'm sure you did more there, but I heard the panel discussion. I was like, I need to get this guy on. He's so on it as it relates to, you know, all things testosterone. So tell me a little bit about your clinic. Do you see guys only for TRT or those who are hypogonadal? Do you see, what kind of patients do you normally see?
Sure. So I have an interesting practice setup. So first, yes, I'm at the University of Miami, but I'm also at the Miami VA hospital. My background and my training, it's urology, but more specifically, I do sexual and infertility. So in a lot of sex med, it's erectile dysfunction, ejaculatory disorders, and low testosterone often goes along with many of those problems. And then on the fertility side, you know, testosterone being a contraceptive, I see a lot of patients on testosterone who are now trying to father children. Additionally, some of the infertility syndromes go along with many hormone disorders. So testosterone kind of falls in the middle between the infertility practice and the sexual medicine practice. So it probably makes up around maybe 30 to 40% of the patients I see on a weekly basis.
So in guys who are trying to get fertile, they are on TRT and they're saying, look, I want to have a kid. How do you wean them off process? Because and we do have some practitioners who listen. Some of them are not. Even those that practitioners are knowledgeable, they listen to this podcast and many others. But just to make it a little simple, what typically happens is when you're on TRT, then your body stops the production of its own testosterone, which leads to low sperm count and things like that. So how do you wean them off so that they start making their own?
Yeah, I'll jump on that too. Testosterone, right? Testosterone is required for sperm production. But where people sometimes get confused, and even practitioners, is that your own testosterone production, right? The testosterone coming from your testicles is required for sperm production. So exogenously,
we haven't figured that out from a pharmaceutical perspective.
Right. So exogenous testosterone, right? The stuff that you're giving yourself, right? That's bad for sperm. And the reason for this is your body will stop producing its own because you're getting it from somewhere else. So yes, it's pretty common that we'll see patients who are on testosterone therapy, either gels, injections, coming in, trying to get pregnant and are shocked that they're not making any sperm. So we take them off of the exogenous testosterone and we'll usually put them on a combination of off-label medications, either Clomid, which it's to kind of simplify what it's doing is it's sort of tricking your brain into thinking you're lower than it actually is to try to stimulate your brain to start stimulating the testicles. We might also use HCG. HCG is an injectable medication that mimics the hormone LH, which tells your testicles to make your own testosterone. And we kind of use those to jumpstart your testicles to try to get sperm production back. We know that if you were to stop testosterone turkey, the majority of patients will start making their own testosterone again. Their sperm production will come back, but it can take up to 2 years for some patients. And the longer you've been on TRT, the longer it usually takes to recover. So the medications kind of jumpstart it.
Question on, just out of curiosity, is the issue with exogenous testosterone and its inability to make sperm in the testicles, is it a proximity issue or is it a molecular issue? In other words, is the TRT that people getting, is it molecularly a little bit different than the one we make naturally?
Yeah, that's a good question. The answer to that is no, it really shouldn't, right? You'll hear this term like bioidentical testosterone, right? It's the same compound, but, say we were to sample the blood, throughout your body, right? That's how we get your testosterone levels. If you were to sample the testosterone levels coming out of the testicular veins, it's going to be an order of magnitude higher. So what's going on inside the testicles is very different than what's going on systemically. So once your testicles aren't doing it anymore, so it's the sperm cells, the germ cells are no longer getting those super high levels of testosterone. I don't think you can replicate exogenously what's going on inside the. So that's the one aspect. The other is there's this other hormone we didn't talk about, FSH, right? FSH is simple to kind of simplify it down. We'll say FSH is trying to tell the testicle to make sperm. When you take exogenous testosterone, you shut down both of those signals. So you're losing the LH, so you're not making your own testosterone, and you're losing the FSH, which is that signal to tell the testicles to make sperm. So so it's a little bit. It's not just like what is the compound, right? There's a feedback loop that's going on.
Yeah, I'm in a natural world, and a lot of people are into bioidentical hormone, and I don't treat or see females. But in my mind, I was like, there is no, they go to compound pharmacies and they get all these mixes. And for women is, some progesterone, some testosterone, and some estrogen. And for men, it's like, no, it's, it's all the same, pretty much. The pharmaceutical version and the one you get it from a compound pharmacy, as best as I know, molecularly is all the same.
Yeah. Yeah. And this was Alex Tatum who told me this, so don't quote me on it. But that term bioidentical, I believe, started from the estrogen world, where there were estrogens that were not the same as what our bodies are making, at least not biochemically. But you are right. Testosterone is testosterone is testosterone.
At least as it relates to men. Yeah.
Yep.
Yeah, I've had to.
Yeah.
If I had $1, I probably wouldn't even have this podcast. I'd be so rich.
Yeah. Yeah. No, it's mostly a marketing thing.
Yeah.
Because it sounds more natural,
Sure.
But the reality is whether it's gel, injection, pellet, it's the same compound. There's just different esters attached to it, which is how it gets absorbed differently, how it kind of elutes differently, and how it stays in your system longer or shorter.
Lovely. How long does it take? So, all right. So they want to get fertile. They've been on TRT. You get them off the exogenous, or do you wean them off? What's that process like?
Yeah. So I tell them to go cold turkey. And I'll say, like, don't stop it today. Wait till the medications that I'm going to put you on get to you, because you're not going to feel great. That's the reality. And sometimes we'll have these patients come in and they'll tell me that they refuse to get off their testosterone. So my general talking points are, look, testosterone, while I know it's important, right? When you stop it, it's not going to kill you, right? If you don't have insulin, you will die. If you don't have thyroid hormone, you'll eventually die. If you don't have cortisol, you'll eventually die. But with testosterone, if you don't have testosterone, like, you'll just live a long, miserable life, right? So you're not going to die. However, if your wife really wants a baby and you being on testosterone is what's preventing that, you might think you're going to die when you stop the testosterone, but your wife will kill you if you don't.
Right.
So those are the two things that you're up against. But yeah, I usually just try to take them off of it completely, so we know what we're with, right? And we know that we can assess if there's anything underlying. So 60% or so of men on testosterone therapy will stop making sperm altogether, right? That's a condition called azoospermia. Now, 1% of men don't make sperm, right? They are azoospermic. There is some overlap with some of those conditions with low testosterone. So if you've never done a semen test prior to starting TRT, right, and you're coming in like to my office, you're on TRT, you have no sperm, right? It's very easy for me to blame the testosterone use as the cause of the infertility problem. Mm-hmm. So I want them to be off the testosterone so that when we're trying to restart their axis, some of those men are going to have a sperm production issue to begin with that we just need to uncover. So I don't want to have any confounding variables, while they're on this road to recovery. So just to kind of summarize that, right? You may have not made sperm before starting testosterone, right? And now, I need to figure out, is your sperm problem because you're on the TRT, or is it because there was something else going on long before that now we need to uncover and figure out?
Interesting. So if somebody, most of the cases you see is men coming, they're already on TRT. I want to have kids. What do I do? But if they come in and they're hypogonadal, they have all the symptoms, ED, and not feeling well, and you say, well, you can be on TRT, you would automatically do a semen analysis first?
I talk to them about it, right? Everyone has different goals.
It depends is my favorite and most popular answer.
Yeah, and that's the reality, right? And I'll tell patients, right, if I have a guy who's in that reproductive age, I will offer them a semen test before starting if they're interested, right? There's a relation of men who know that they're never going to have kids and don't really ever care, or don't care to, and they usually forgo it. Right. Some patients have the concern so much that they actually want to freeze a sample before starting testosterone replacement because they may not want to come off of it. And just to now kind of go back to the recovery thing, a lot of patients will come off their testosterone, go on the HCG Clomid combo only long enough to get a sample to freeze and go right back onto testosterone therapy.
Oh, fascinating. Okay. And that's their choice. And that's cool to do, right?
Yeah, absolutely. I mean, as long, in the infertility world, I say there's very rarely a right answer, right? There's going to be a bunch of different options. You just have to figure out what makes sense to you. And my goal is to try to get you there, right? The downside to freezing the sperm is you're probably going to have to use, IVF. You're going to have to do IUI at least, right? Or you may need to go on for IVF. And there are costs associated with that, right? And you want to discuss realistic outcomes for the pregnancy aspects. But each couple, they again have different goals.
Roughly, and I know you're going to say it depends because it should depend. But on average, how long does it take for those that are interested in remaking their own semen and sperm? How long does that process take from the time they get off TRT, they get on ACG and Clomid? Roughly, how long does that take?
Yeah, it's going to be a minimum 3 months, but I tell most patients 6 months is probably a good time point. Okay. So if we don't have any sperm by 6 months, that's when that flag goes up to say, maybe there's something else going on here. By 2 years is when 2 years is what I was saying. If you stop testosterone altogether, 2 years is when it may take some patients to get sperm recovery. So as if by 6 months you're not seeing anything, or we're not seeing the numbers we would expect, that's when we start trying to do some other things. Either work them up for what's called active azoospermia, or sometimes we'll add in the medication recombinant FSH. The reason I personally sort of say delay to 6 months is, none of these medications are covered by insurance. They're mostly coming from compound pharmacies, and there are definite costs associated with all of them. And of those medications, the recombinant FSH tends to be the most expensive.
Well, good to know. Let's move on to another area in the pelvis, the prostate, and its association with testosterone. We go into BPH and prostate cancer. Any association or relationship between testosterone and men with prostatitis? In my mind, it's I don't think so. It's prostatitis, a little bit of diagnosis, a weird diagnosis, wired diagnosis of exclusion. It's more like pelvic pain or chronic pelvic pain, so it's weird. But anything at all?
No, I don't think there's a direct relationship between the two, meaning men with low testosterone being more prone to, or men with high testosterone being more prone to. I don't think so. Yet. But there is definitely that relationship between, testosterone and growth. Right. Which is BPH.
Right. So let's go right into it. So give us a little bit of, I love the way you're speaking with me because I don't have to bring you back to a little bit more simpler language for our audience. So you're doing great. And I thank you for that because I know we can geek out if we're not careful. If you can tell us, that relationship and how that works, including conversion to DHT and all those kinds of things.
Yeah. So basically, right, all men have prostates. Your prostate is this gland that sits kind of between your bladder and your penis. And it does really, we think, only one thing, which is create for your semen, right? So PSA, that's, that blood test, that screening test for prostate cancer, what PSA actually does is it liquefies the semen. So your prostate, unfortunately,
and provokes anxiety in men.
Yeah. So once you hit your 40s, it pretty much starts to grow in almost everybody, right? What we really don't know is why it does this. We just know that it does, and we know that it uses testosterone in that growth. So testosterone is converted to something called dihydrotestosterone by an enzyme called 5-alpha reductase. Mm-hmm. And this exists primarily in men in two places, the prostate and the hair follicles, right? So that it's that dihydrotestosterone, that DHT, that really stimulates prostatic growth. So, one of the two classes of medications we use to treat enlarged prostate is a medication that blocks that conversion of testosterone to that DHT. The name finasteride, dutasteride, Proscar, right? That's what we typically give to try to slow that growth down. It doesn't stop it, but it slows it, right? It'll shrink it initially, and then it starts to continue along.
Pause there for a second, if you don't mind, Tom. To guru members of sexual medicine, Mohit Khera, John Mohan.
Yeah.
They're not big fans of 5-alpha reductase inhibitors. They're not big fans of stopping that conversion because DHT, if we're not careful, it sounds like the bad, it's like cholesterol. It's like saying cholesterol, lower your cholesterol. Well, cholesterol is sometimes found in a crime scene. It's not the criminal. Can you expand on that? Because I think that our audience would want to hear about it. And I'll tell you what I know. The reason why men would take a 5-alpha reductase inhibitor is so that they have lower urinary tract symptoms. Mm-hmm. At the end of the day, that's all that matters. Well, Correct. We've seen that, the prostate does shrink, maybe 20, 30%. I don't know. You correct me. But not always does it reduce the urinary symptoms.
Correct.
So,
Yeah.
You've been taking care of your health, regular checkups, staying active, trying to do all the right things, but lately you've noticed something's changed. Maybe you've more tired than usual, your motivation dropped, or your strength and stamina just aren't what they used to be. These all can be signs of low testosterone, a condition that affects nearly 1 in 3 men in the United States. Kaisertrex is an FDA-approved oral testosterone replacement therapy that helps restore testosterone levels back to normal. It's not an injection or a messy gel, just a simple twice daily pill that fits easily into your routine. Find out where you stand. Order a testing kit today at kaisertrex.com/testing-kit or look at the link below in the show notes. By prescription only, Kaisertrex is a controlled substance and can be a target of abuse. Kaisertrex is not for use in pregnant women or men with prostate or breast cancer. Safety and efficacy in those younger than 18 is not known. Tell your doctor about all medications and conditions. Serious side effects could include increased blood pressure, worsening prostate problems, increased risk of prostate cancer, blood clots in legs or lungs, liver problems, enlarged or painful breasts, and breathing problems while you sleep. Common side effects include swelling of the ankles, feet, or body, increased red blood cell count, and increased PSA levels. PSA is a test used to detect prostate cancer. Report these symptoms to your doctor. Call your doctor to learn more about Kaisertrex. For questions or information, visit www.kaisertrex.com or call 1-833-949-5040. Symptoms.
Correct.
So,
so that's a good distinction, right? So prostate growth in and of itself isn't really a problem. In fact, LUTs, what we say, lower urinary tract symptoms. This is, the hesitancy, urgency, waking up at night to pee. Again, them by themselves are not any kind of life-threatening condition, right? You're talking about quality of life. So we treat enlarged prostate based on the symptoms and the amount of bother, right? You can have your normal size prostate is about 20 cc's, right? we have some, which is about the size of like, a walnut.
Mm-hmm.
We have some patients who have prostates the size of like a grapefruit, who have absolutely no symptoms, who could not care any less, right? That's fine. You don't have to treat that person, right? We then have this other group of patients, right, who may have very small prostates, but are very symptomatic. And we think it just has to do with the direction of growth. So if it's growing in towards the urethra, or it's growing into the bladder and obstructs the flow of urine, those are the people who have problems, right? It's not the guy who just comes in who's like, incidentally finds on like a CT scan their prostate's big. It's like, who cares, right? Now, you are right. The 5-alpha reductase inhibitors do shrink the prostate, and they can be helpful in correctly selected patients. So in your symptomatic patients with a large prostate, it's going to shrink it about 20%, and hopefully, improve some of those symptoms. Now, the 5-alpha reductase inhibitors are also used for hair loss. So you have this totally other group of patients on them who are, these younger guys. By young, I mean the late teens, 20s, 30s, who are taking Propecia, which is the same medication, finasteride, right, for hair loss or prevention of hair loss. And there are dysfunction side effects associated with these medications. And that's why they have they get a bad rap, right? For your older gentleman who's very symptomatic with LUTs, probably, the risk benefit ratio is in favor of taking those medications. But for, the younger guy taking it for preventative reasons, who now is having like fatigue, issues with erections, probably wasn't a good option for them.
Right. And guys, they tend to enjoy their nice hair too. I think the viewers, we have viewers and listeners, depending on what platform they use. And the viewers will say, we'll start connecting dots. Dr. Geo, your DHT, is pretty high or pretty low. Is it high? Wait a minute. No, it
depends if you're taking
right, exactly. And they'll look at Dr. Masterson and say, well, his DHT levels, they're probably low. He's probably doesn't have to about that because you have a nice full set of hair.
Yeah, I've been lucky, right? But I'll tell you this, on my social media platforms, for one reason or another, I'm just getting hit with hair loss commercials over and over and over again. Yeah.
Interesting.
Yeah.
There are times where people come, they want to see me for hair loss. And I'm like, have you looked at if I would have figured this out a long time ago, I would have known. That's not.
Well, I didn't mention this before, but when you were talking about like when we were back on testosterone fertility, those patients that I see, a lot of them, I feel like are getting targeted ads for men's health clinics because, the testosterone world is really expanded. Yep. And now there are online sources and things like that where you can get testosterone replacement. And similarly with the hair loss, right? I'm joking a little bit about like the targeted ads, but I am getting those targeted ads, right?
I'm sure you are.
And it's one of those things, the more you see these things, like, maybe I will call, and then they put you prophylactically on like minoxidil and Propecia. And, it's just much, how do I say this? It's like the risk to getting access to these types of medications that may have long-term consequences. The barrier is getting lower and lower.
Mm-hmm. Yeah. And it's a problem. And then some of them have finasteride-induced syndrome, which some people argue whether it's a real thing or not a real thing, where they have these long-term side effects or not, but it could be a problem. So going back to, testosterone is converted to DHT. It is thought that DHT stimulates the prostate and makes it grow. But DHT there's benefits, and a lot of the maleness of, comes from DHT, even sometimes more than testosterone, because DHT is even more powerful when it hits that receptor than even testosterone. So it's like, well, what should I do? You can answer that, and I also want to ask you about, certainly from my research, and when people come to see me for natural methods for what I call functional testosterone, by the way, which is, it's not just total, right? There's a few other things that need to be right. I find that the ratio matters between testosterone and estradiol. So in other words, when estradiol is very high, and this is based on research, relative to testosterone, that also stimulates the prostate to grow. Your thoughts on DHT? Is it really the culprit? Is it the only culprit? Or is there something else going on?
Yeah, it's a good question. And the reality is, like, I don't know the answer. When we are working people up for BPH, like I do not routinely check estrogens. I'm not routinely checking DHTs or really anything. I don't even really check
SHBG?
testosterone level. No, not when we're at least for working up BPH, right? And I'll tell you, like my go-to drugs are not the 5-alpha reductase inhibitors. First and foremost, it's lifestyle interventions. What's really bothering you? Is it nighttime urination? Are there things we can do to improve that? Fluid reduction, think about when you're taking diuretics and that kind of stuff. Is it the frequent peeing? Are there food, beverages that that are triggers? Yeah, exactly.
Issues, yeah.
Looking for sleep apnea, that kind of stuff. When it comes to actual medical therapy, alpha blockers are generally first line because again, they work on the muscle of the prostate, cause like relaxation. And they don't have the potential hormonal consequences of a 5-alpha reductase inhibitor. So that's usually my go-to. Now they have their own issues, sexual disease, not so much the ED, the libido and all this, but retrograde ejaculation. What that means is when you're having sex or you're masturbating and you're hitting climax, when you orgasm, normally fluid comes out the tip of the penis. On an alpha blocker, you may not see that.
Right.
What's happening is going the path of least resistance, which may be backwards into the bladder.
So these are your tamsulosins and
Tamsul, Flomax, doxazocin, terazosin, basically all the
zosins. But there is one flea, I think it's uroxetrol, or right? Isn't there one?
Yeah. I think doxazocin and aflazocin are the two that have the least retrograde ejaculation. The other part to that is those are titratable, right? Floma is really, or tamsulosin it's a one size fits all. Same thing with like silidocin. Those two are probably the worst, but give you the most improvement in your urinary symptoms. So it's kind of a trade-off. It becomes a challenge for many patients who want to maintain their ejaculation. Sometimes you just tell them, look, do you want to pee better or do you want to keep your ejaculation?
Right. They do. I have to say, as a natural doctor, I do have my go-tos with pharmaceuticals, and those alpha blockers, amazing. Little side effects is great ejaculation. A few people with sinusitis, they get more symptoms, but not often.
The the hypotension, right? Yeah. The orthostatic, where if you stand up too quickly, you might feel lightheaded.
Yeah, because isn't it used or used to be used for blood pressure, high blood pressure?
That was, it's one of those medications. I mean, that's the same thing with like Viagra.
Incidental findings, right?
Yeah. We're trying to treat pulmonary hypertension, but people are also getting erections.
That's right. One of those. Final thoughts on DHT, because that's a question that keeps coming up. Is it a problem, or is it is it a problem? Is it a ratio problem relative to testosterone to DHT? I don't think I ever have an interest, and I just want to get it right. I never. Yeah,
no. The truth is, I don't know. And even if you look at guidelines for BPH management, we don't order it routinely.
Yeah.
So I don't have the answer. I really don't know.
Yeah.
But we do know, what we kind of do understand is you're right. Estrogen is involved. We don't really have a good idea to what extent and whether or not we should be intervening on estrogen levels. And same thing with DHT.
Right. Yeah, with like aromatase inhibitors and things like, which is I'm not a fan. Great. So that is as it relates to BPH. So let's say you get somebody on TRT. One would that their prostate will get enlarged, either by the conversion of testosterone to DHT, if indeed that's the only pathway, which we're trying to figure that out, or just by stimulation of the prostate, where the prostate grows if you get them on TRT. Is that the case? And does that sometimes increases lower urinary tract symptoms in patients that are newly treated with TRT?
Yeah, great question. So great question with not a great answer. So it depends on what you read, right? There are some studies that, we use snares, right? How do we determine someone's urinary tract symptoms, and how do we determine how bad their BPH is, right? It's the prostate size and measurement, as we discussed. It's the symptoms. So, you're taking patients with low testosterone who potentially have lower urinary tract symptoms, put them on testosterone, and now they're taking those same questionnaires, right? Some studies do show worsening of those symptoms. Others do not, right? One thing that we sometimes use as like a surrogate for BPH and the size of the prostate is PSA, right? PSA is that blood test. It's a screening test we use for prostate cancer. And what we do see is that in hypogonadal men, right, who start testosterone therapy, there is an expected increase in PSA levels, right? So it may be stimulating prostate growth. Now, we also said PSA is a screening test for prostate cancer. So this also leads to some concern about, are we stimulating prostate cancer growth? Because these two things can happen together, right? So we'll kind of like paint the picture here of like how we think about it. So if you think of like the receptors for testosterone, right? Think of it almost like your gas
or
tank.
lock and key, or
Yeah. Well, I'm thinking of it like if you're supposed to be running, with your tank full, right? But you're always at half empty, and now you're filling it up, right? What's sort of happening, right? So you may be with the testosterone, finally filling the tank, and now your prostate's sort of responding to that. And then at some point, right, you can't fill it anymore. So we think that, like, again, in the hypogonadal patients who get on testosterone therapy, their prostates may just be now getting the amount of testosterone they were hoping they were expecting, and you're getting a response to that. Compare that to, say, somebody who's got like normal testosterone levels, you put them on testosterone therapy, we may not be seeing that same elevation in PSA. We may not be seeing, that change in prostate size because the prostate's been getting what it needed the whole time.
That's Morgenthaler's saturation point or something like that along those lines?
Yeah, the saturation hypothesis, right? This idea that, once all of the receptors are filled, right, it doesn't matter that you throw more onto it. So, I think we've arbitrarily conversationally used this number of like 250, which has never really been proven. But once you get it to some point, like, is there a difference between your testosterone level being at 500 versus being at 1,000, right? Once the receptors are filled, they're filled. Now, I will caution, right, it's still a hypothesis. This hypothesis was sort of only taken from data looking at prostates, and specifically like prostates in mice, right? So testosterone's effect on other things like bone health, libido, erectile function. We don't know if that, right? We don't know if that saturation model, right, applies to those other areas at the same levels, right? So the brain may be very different than the prostate or the penis.
You think it is, but maybe.
Maybe, right?
Yeah, right.
Maybe. I don't know.
Yeah.
Because I'll tell you how many, I mean, you probably see this too. Like, how many patients come in and say, doc, when I'm at 1,000, I feel so much better than when I am at 800. And, in my head, I'm thinking, again, saturation model, like, this is probably placebo, but maybe there's something there.
Right. Or maybe there is more free with 1,000 and 800, I wonder. And that more, Tom, I've seen guys 800 with below 2% free.
Yeah, this is also a strange thing. So, free testosterone, total testosterone, for whatever reason, the guidelines only talk about total testosterone levels, which I think is misleading, right? Because at least in groups of people who do a lot of testosterone replacement, we recognize exactly that, right? There are patients whose free testojesterones can be incredibly low despite normal testosterone levels. And you're not really sure what to do with that because the way the guidelines are written, right? We'll use the AUAs, the American Urologic. They use total testosterone of 300. They only mention free testosterone when something is equivocal. Mm-hmm. But, 800 total is not equivocal. That's just normal.
Yeah, exactly. And I've seen guys 300, 350 with a significant amount of free, and they're asymptomatic. So it's a very interesting thing. And I wonder if it's insurance driven a little bit. So, they only cover when it's under 300 and not cover when it's over. Is there some of that in there?
Well, I feel like, that might be the dog chasing its tail, right? Because, insurance tends to follow, what the literature and the guidelines show. So if the guidelines are talking about total, but you're talking total testosterone, then that's what your insurance company is going to follow.
Right.
Because I have those issues all the time with pre-authorizations where, if the total testosterone is in that 300 to 400 range, guy symptomatic, insurance denies. which fortunately testosterone is relatively inexpensive using like GoodRx coupons or compounding pharmacies. So it's not a huge deal, but when you're paying into an expensive insurance plan, you want your stuff covered.
Yeah, that's right. That's right. Any final thoughts on testosterone as it relates to BPH? So a guy, so you have them on TRT, let's say another example, and now they have lower urinary tract symptoms, whether it's associated with testosterone or not, because of course you blame half, right? So if you have the
Yeah.
prostate, it has to be the prostate, which is not the case. It could be the bladder, it could be overactive bladder. But let's just say you get them on TRT and for some odd reason they have LUTs. What do you do? Do you get them off testosterone? Do you give them a 5-alpha blocker? What do you do?
Yeah. It's a discussion with the patient, right? It's kind of goal oriented. So, if they feel great on the testosterone and their initial symptoms have resolved and this is now a side effect of it, you talk to them about the options. Try the alpha blocker, right? Talk to them about behavioral modifications or so forth, and then decide, what they want to do. But I wouldn't just, knee-jerk reaction. I wouldn't just take them off the testosterone therapy. Even PSA elevations, I usually don't knee-jerk take them off testosterone therapy if they've had symptomatic improvement.
They go on TRT and they have a strong family. Their father got diagnosed with aggressive prostate cancer. You don't go on TRT. They see you for TRT. Do you change your approach in that scenario or no?
The only thing I change is how frequently and at what age I'll start PSA screening them. So if they don't have any sort of family history and we're putting them on testosterone therapy, I'll include PSA screening usually at like age 40. But depending on family history, I would start it sooner, much as early as 35. But you will get some pushback from insurance companies about covering those tests. But no, I go about it the same thing. You talk about the risks. What we understand about testosterone therapy is that it really does not, right? I should almost say this. It almost conclusively does not cause prostate cancer, right? Meaning in the best studies looking at large populations, there is not a higher incidence of prostate cancer in patients put on testosterone therapy compared to those not on testosterone therapy.
It's
right?
pretty conclusive in 2025, isn't it?
Yeah. I mean, the way I feel like the sort of like the history of testosterone is, testosterone, people started using it. It immediately gets a bad reputation. A lot of black box warnings, a lot of cautionary tales. And then we've spent the next, 30 to 40 years trying to sort of check each one of those things off and try to remove them. So, the most recent, I would say, victory for testosterone is the removal of the major cardiac events, heart attack and stroke due to the MACE trial. So the warnings about prostate and breast cancer, they're still there.
Even despite the Traverse trial indicating otherwise?
Well, the how do I say this? We don't say anymore that it causes prostate cancer, but on the label, it still tells you that if you have active prostate cancer or you have active breast cancer, that it is technically contraindicated. First trial was great for MACE, right? Major cardiac events. Yeah,
that's what I meant. But it's ongoing to look at the big question as relates to prostate cancer. Is it not eventually?
So, this is where I've had some arguments. So I will now talk about my personal problems with the Traverse trial, right? My problems about, globally applying, all of their categories, right? The trial was designed to be looking at cardiac events. So they had patients with low testosterone with multiple risk factors for cardiac events, right? Put them on testosterone therapy or a placebo using gel, and then find out to see was there a difference in things like heart attack, stroke, blood clots, and so forth. And, long story short, they didn't see any difference between the two groups.
Even with those patients who had a history of cardiovascular disease.
Oh, yeah. They all, right? So to enroll, you had to have some sort of risk factor, right? In this trial design, right, they used gel. I both know absorption is very different in gels, patient to patient, compared to, say, injectables. And they wanted to titrate patients middle tertile, which is like 450 and above, right? So if you look at where they got the testosterone levels for the group on testosterone therapy, and I don't have it in front of me, but I believe it was around like 370, right? Which is response, right? All the patients below or before starting were at least under 300. But then if you look at the confidence interval, right, the difference, there of the where patients were, right? It wasn't everybody was 370. Many patients on that study were still technically hypogonadal because even on the gel, they were less than 300. And then if you want to use sort of more liberal, cutoffs, right? The American Society for Men's Health uses a cutoff of 350, right? So now you're saying even more patients using those criteria were hypogonadal based on a difference. So in my mind, they didn't really hit the testosterone levels that they were hoping for.
Because now the modality that they used.
Because of using the gel, and I think they were trying to, right? They didn't know what was going to happen. And it's much easier to tell somebody to stop a gel and their testosterone levels will return back to where they were within a matter of days to weeks versus injections, right? Where once it's in there, it's going to be in your system much longer. So that's my take on it. So now so knowing that the study was designed for cardiac events, right? That's the first thing. Second thing is, because I'm trying to transition this into the prostate cancer discussion. They screened out patients with prostate cancer. So if they'd had a diagnosis of prostate cancer, not on the trial, right? You think they used a PSA cutoff of 3. So if they had a PSA greater than 3, you're not on the trial, right? So they removed patients who were higher risk to have undiagnosed prostate cancer to begin with. So that's the group we're working with. So now to put them on testosterone and say, there was no difference in prostate cancer outcomes. Well, first, that wasn't how the trial was designed, right? You pre-screened patients so that people who were higher risk of developing prostate cancer were removed. And then the third thing is, we know that generally prostate cancer takes a long time to grow. So one of the concerns is that testosterone might be just like fertilizer for prostate cancer, and that it's just going to, if someone has prostate cancer, it's just going to take off, right? And that may also not be true. So I don't think there was the study to answer that question about like the safety of testosterone in patients with undiagnosed prostate cancer and so forth.
Are they going to attempt to answer that question moving forward, or are they going to just stop it and say it's not, no issues with cardiovascular disease and that's it?
Well, so the cardiovascular, they took that off. That's now, as of I think like 3 weeks ago, removed. Like the FDA had an announcement that they're removing the cardiac events from the label. Okay. But the prostate cancer discussion is still definitely ongoing.
All right. Thank you for clarifying that. I guess I didn't look at it as deeply and thoroughly as you did.
Yeah. The only reason was this was a debate that we had at the AUA, which was on that topic of prostate cancer. Is it safe to put a person on active surveillance for prostate cancer on testosterone therapy, right? And there is no prospective trial answering that question. We have retrospective studies, we have population-based studies that I would say are sort of hypothetical driven, meaning like if you put 1,000 guys on testosterone therapy who are in their 60s, right? Some percentage of them, just by the nature of prostate cancer and the disease, some of them were going to have prostate cancer to begin with. So that's the kind of the thinking that's gone on to sort of say that testosterone probably is safe with people on active surveillance, but we just still don't have a trial answering that question directly.
So that's my next question. Is testosterone safe for people on active surveillance?
The answer is probably, but we don't actually have. So, again, it's generally small studies. Yeah. Larry Lipschultz's group has their retrospective things with Abe Morgenthaler, where they had patients with low risk prostate cancer with low testosterone who they put on testosterone therapy. But, it's retrospective. Right. And the problem becomes, you don't, with any retrospective study, the way you have to identify is basically using your medical record system, using diagnosis codes or medication orders, and look. So we didn't get testosterone therapy, right? Or what were the reasons behind this patient getting testosterone therapy and not the other one? If I have like an 80-year-old with, very low risk, low grade prostate cancer with, in a very low testosterone, right? Like I probably feel a little bit more comfortable putting that patient on testosterone therapy because they're older, right? Even if testosterone therapy is going to stimulate prostate cancer growth, it's still probably going to be over multiple years, and they may end up dying from something else other than the prostate cancer. Now, the 50-year-old who's hypogonadal with a low-grade prostate cancer, I may feel a little bit differently about putting them on testosterone therapy because they may have a higher likelihood of an adverse event. So when you're looking at a retrospective study, you don't know what reasoning went into why those patients got the therapy. And that's why prospective studies are good because you generally try to have a comparison group, right? You have very strict criteria ahead of time to select people into the trial. So
we have a failed opportunity with the Traverse trial.
Well, it's just not what it was designed for.
But you could have included that as, you know what, maybe the PSA cutoff shouldn't be just this. Let's include everybody. Even with a history of prostate cancer, right? Because isn't that one of the questions we're trying to answer anyway?
It is. But Traverse, the way Traverse was designed, the way it came up was really the FDA wanted to answer this question.
One question, yeah.
So it was a drug. I may be wrong, but this is what I remember. That was a industry sort of sponsored trial where most of the pharmaceutical companies got together, right, and said, we're going to answer this question because we want to get this off the label, an answer once and for all. I shouldn't say we want to get it off the label, right? They wanted an answer to the question, and that was a potential benefit of the trial. Because it sounds more like they may have washed the number, but that was the question they were answering, right? When you design any trial, you generally have one question in mind that you're trying to answer. So you then to get that patient group that's going to get you the answer to your question. And quite frankly, you don't want to have a bunch of unintended consequences that may shut the trial down early. So if I were also designed, so if I'm trying to ask, does testosterone therapy cause cardiovascular events? If there's any concern about the prostate cancer issue, I'm going to remove it because I don't want to get shut down early and not be able to answer the question that we want if we find that, people's prostate cancer is progressing, right? So I think what they did was the right thing for that trial.
So men on active surveillance, there's a good chance that you have men on active surveillance on testosterone. I know men on active surveillance on testosterone. And I think the clinical experience is valuable. So certainly in my philosophy, we know that research is hard. Getting information and only practicing research-based practice, that's very difficult. Things can take up to 17 years to be in practice. So we're in the trenches. But we have a decent understanding, and particularly in urology, how things work, and we have to do off-label things at sometimes, and repurposing drugs at other times, and figure things out. So clinical experience matters to me as much as the research, sometimes even more, particularly if somebody's an expert in the field. So do you think, based on what you know, that testosterone, and of course, a man on active surveillance, their disease can progress, but that could be despite the disease.
For sure.
Despite testosterone. So do you think that there's a possible issue, minute issue?
Yeah. So I'll give you the kind of the arguments, right? So if you think what is the difference between a hypogonadal guy on active surveillance versus a eugonadal guy on active surveillance?
Eugonadal meaning normal testosterone.
Meaning normal testosterone levels, right? So why aren't they at a different risk of progression, right? Or what makes their risk of progression different, right? this guy's testosterone levels are in like, say, the 500s, and this guy's are in the 200s, is bringing that guy from the 200s up to 500, putting him at a different risk than the guy who was already at 500. Is that kind of
I understand, and the answer would be they shouldn't be at a different risk, or
right, they shouldn't be, and that is the argument as to why testosterone therapy should be safe, right, for patients with low testosterone on active surveillance.
Now, let me ask you a question. I mean, first of all, I'm all into men who are hypogonadal on active surveillance to have, full life and to be on testosterone. I can't say that I've seen many problems, but just thinking, right? A hypogonadal man likely has, and correct me if I'm wrong here, a hypogonadal man probably has less androgen receptors going on because the cells are saying, look, we don't need that many receptors because there's not enough testosterone. So now you have a hypogonadal man who on testosterone with not that many androgen receptors, maybe start stimulating some with TRT. Again, just thinking scientifically and biologically, any issues potentially with that?
It's a good question. I don't know.
Right.
Because even with the what you're proposing, right? So I don't know, because I don't think it's really ever been tested, because so testosterone being a steroid, right? Compared to, it's very easy for us to measure surface receptors on cells, but internal receptors, where steroid receptors exist inside the cell, it's much more difficult to measure them. So we often have to look at their downstream effects as a way of seeing what's going on. So I actually don't even know that, like, in a hypogonadal guy, are his testosterone receptors down regulated compared to a eugonadal guy. So I don't know the answer to that question. So, which then brings on the whole next question about, like, again, what you're saying, this, safety with testosterone therapy. I don't know, but at least in the best, small retrospective studies, it doesn't really look like there is a safety issue.
Or in your experience, or in any conference that,
Yeah. I am definitely on the more conservative side of things.
It sounds like for sure. More than others.
Yeah. Because, I joke around that some of my colleagues would be like, it's like, oh, your elbow hurts? Throw some testosterone.
Right, exactly.
But no, so for me to put somebody on active surveillance on testosterone therapy, there's certain they're going to have to meet. First, they're going to need to be truly symptomatic, right? And I don't mean I just have erectile dysfunction, right? Testosterone in and of itself is generally not a good treatment for ED.
Yeah.
Right? So, but a lot of people coming in say, I have ED, my testosterone must be low. Right. So if their main complaint is erectile dysfunction, treat the main complaint symptom. Right. So that's the first thing. They have to have truly, like, the hypogonadal symptoms, libido, erectile dysfunction, energy, mood, all of it. Second thing is they have to have low risk prostate cancer. Right. And by that, I mean, Gleason 6 in very few cores. Right. And they have to have had at least one confirmatory biopsy. Preferably now, and we have MRIs on most of them, and I keep them on a active surveillance schedule that is a little bit different than our standard patients. So I check their PSAs more frequently. I'm usually getting an MRI like every year. So I am a little bit more conservative, I would say, than most. I get nervous when I see that there's Gleason pattern 4, and I also probably am doing this more if I were to look back on it in the older patient population compared to the younger guys. And this is just, again, my biases.
When there's no data, it's all about, you got to depend on your body.
Definitely.
Than you are.
No, and I will get more comfortable. Like, once I see, like, better, sort of more robust data, because I always think about what's the worst thing that can happen, right? That's what you always want to say. As we started off at the beginning, no one's going to truly, like, die of their low testosterone. They may be miserable, right? But what is the worst thing that could possibly happen? If they do have higher grade prostate cancer that maybe wasn't diagnosed, right? And we potentially make that worse. Like, you can't fix metastatic prostate cancer, right? You can manage it, but you can't fix it. So that's always, like, in the back of worst case scenario. So if you can manage many of those other symptoms and avoid that outcome, that's sort of what my reasoning is. Because just, for your viewers who I'm sure know, right, for advanced prostate cancer, right, not these low grade, low risk, active surveillance guys, advanced prostate cancer, still, this sort of standard treatment, the first thing is removing testosterone, right? Chemically, right? Or in the olden days, surgically, castrating men, trying to get those testosterone levels down. Because what we do know is advanced prostate cancer does use testosterone to grow. And by removing it, we actually see that it shrinks.
So then I think I could answer the next question.
Yeah.
Guy Gleason 3+4 successfully treated for prostate cancer. 2 years out, PSA undetectable, hypogonadal ED feels like crap.
Oh, I treat that. I give them testosterone.
Okay.
Yeah. So in the treated world, no. So in the treated world, I can view this so very, very differently.
I see.
So like treated prostate cancer, and this is actually, I think this data came out of the VA, at least for radiation therapy. If they had cancer, let's take this one at a time. So prostatectomy. They've had prostate cancer, prostate is removed, and the PSA is undetectable. As long as they are intermediate risk or lower, at 6 months, I'm comfortable giving them testosterone therapy, right? For high grade, high risk prostate cancer, so if they're like, Gleason 9, Gleason 10, right? I'm a little bit more conservative. I see PSA to be undetectable. I may wait out to a year in that group, or if they had other things like extra prostatic extension, positive margins, things like that, I will wait a little bit longer. But as long as that PSA goes to 0, I'm usually pretty comfortable. For radiation therapy, low risk patients, I'll wait about a year. Higher risk patients, I wait for 2 years. And what I'm waiting for is that nadir, right? I try not to get nervous with the bump that we usually see at that 2-year mark. But no, as long as their PSA is down consistently low, I don't have testosterone.
It's funny. It sounds like you're more willing to treat those that have had a more aggressive prostate cancer, but treated hopefully successfully than people on active surveillance. I feel the other way. I mean, I feel fine both ways, but I feel more the other way because active surveillance is almost like no one dies from Gleason 6s. I think that Scott Egner and those people, they're like, why are we even calling it cancer? Right?
No, you bring up a very good point. And it's like, how do I say this? Someone told me this one time, and it's really good. It's like, once touched, a butterfly never flies the same. So the minute you've seen your Gleason 6 guy, turn into something else, your mindset changes about it. And you always have those, anecdotal patients. And the reality is they probably Gleason 6 to begin with,
Correct.
Right? It was probably they had some pattern 4 in there, maybe even pattern 5 that just didn't get picked up on the biopsy. Fortunately, we have a lot more tools today than we did even 10 years ago, right? In residency, we were not ordering MRIs with any regularity for prostate cancer screening or follow-up for active surveillance. We also weren't using many of these genomic marker tests in either diagnosis, active surveillance, decision-making. Right? We have that available to us now. So you are right. There are people out there who really do feel that Gleason's pattern 6 or Gleason 6 just doesn't really do anything. They may be right, but when you see the patients who did have a Gleason 6 biopsy and on their repeat biopsy it turned into 8, right? The question is, well, was there always some Gleason 8 in there that we just didn't get on the initial biopsy, or did it progress?
Yeah, we wouldn't know that. And likely the former, I think, happens, although hopefully less in this day and age, just because of the technology, the MRIs, even some of the genetic scores, I think is helpful.
Yeah, actually, just because you have, your viewers around here. So because I work in the VA system, we have a medical record system that dates back, well into the 90s. Right. And I will see patients here who have biopsies that are Gleason 4, Gleason 5. Right. I'm not saying exactly. It's not 4 plus or right. Things that don't even get reported today because back then it was more concerning, and they would, put pattern 2, pattern. They don't do that anymore.
Right.
So things may change in the future, but for now, right, Gleason pattern 3 or pattern 3, Gleason 6 still reported as cancer.
I guess my last question is, what do you know about bipolar androgen treatment in men with advanced disease that have been on hormone therapy? I'm trying to get Dr. Dan Mead on. It's impossible. Hopefully I can corner him at the AUA or something, because I know he's a thought leader in this. I haven't seen much published on this as of late. What do you know about that?
Not a ton. That's the reality. So when I was in residency, I think there was some papers coming out about it where, what bipolar androgen therapy, meaning right, we normally do androgen deprivation, where we're actually removing all the testosterone. This is the opposite idea, which is now like flooding it with testosterone. And at least, in whatever small series that I remember, they showed some positive response, meaning like the patients weren't really getting, and in some cases actually saw potentially shrinking or regression of some of the metastases. But it is definitely not, it is not something that I do, and I don't advocate for it, because again, I'm on the more conservative side.
Yeah.
And because again, what is the worst case that can happen, right? You can potentially worsen their situation and potentially take years off of their life. I'll bring this in, which is like the anecdote, so that like Abe Morgan is, they're dying with dignity, where if you have somebody with advanced disease, they're miserable on androgen deprivation therapy, right? They can't get out of the house. They can't do any of their things. You giving testosterone in like a compassionate setting is, I think, different from what we're talking about with this bipolar androgen treatment.
Right. And I know there are practitioners who are willing to do so in this compassionate approach, which, it may, I think I'm always looking at it from a patient's perspective. I have a prostate cancer patient who just decided ADT, and his PSA, this is post treatment, and his PSA, and he doesn't have patient stimulated anxiety through the PSA. He's like, no, you know what? I don't care what my PSA is. I want to have testosterone. I feel so much better, and I feel like crap on ADT.
There's nothing wrong with patients making informed decisions. Right?
Exactly. Yeah.
You talk about the risk. I mean, we over here at the VA, I have a lot of patients who have PSAs in like the 200s, who don't want a biopsy, who don't want any sort of treatment, because and we talk to them about it, and they say very similar things, right? Doc, I feel fine. I understand that I likely have prostate cancer. I understand it's likely spread, but right now I have no symptoms. My quality of life is good. And once it becomes symptomatic, then we can talk about treatment.
That's not an unreasonable approach if you're making an informed decision, I think.
Yeah. Don't get me wrong. It makes me super nervous, right? Every time I don't know if I'm going to see him next time in a year.
Yeah.
But as long as you have that discussion with patients, it's their bodies, their choices, right?
Self-health advocates is what we call them here. And again, informed decision, A, and B, and what you think today may change in 3 months, 6 months, in a year. It's like, oh man, you don't want to have regrets. The approach, I think it's, more power to you. I think that's a great thing.
Yeah.
Final thoughts, Dr. Masterson. We're about to wrap it up. Thank you so much for being on. It's a great discussion. I loved your thoughts on a Traverse trial, because I'm not a PhD. I'm not a scientist, which means, and I'm Cuban, as you know. So that means I have a lot of emotions, and sometimes I have to control it because I'm trying to be unbiased as I, read and interpret things. So Traverse trial, yay! No problem with cardiovascular disease. And I was like, wow, those details, the devil is in the detail. I still think is a right thing, but I didn't read it thoroughly enough. So I jumped on the bandwagon.
And I'll say this: I'm not trying to knock that trial to say,
you're looking at it correctly.
This was a waste of millions of dollars of money. Not at all, right? I think it did answer the question that it wanted to answer. And again, enough so that even the FDA said we're going to remove it from the label. With any big trial like that, there is this you want to publish as much as you possibly can with your results, because it's very rare to get thousands of patients enrolled into a trial.
Yeah.
So they like to do what they call like subgroup analyses, but you just have to be cautious in how you apply that subgroup analysis, broadly.
Yeah, I agree. Any other final thoughts?
No, I mean, Gio, this was great. I really do appreciate, you inviting me on. Hopefully to your listeners, this was fun, informative.
Absolutely.
Just really appreciate it. Thank you again.
How can people find you? Somebody in Florida, I need to see him. How can people find you?
Oh my God. The easiest thing is, I hate to say it's like my email, but if you want to see us, first, I'm in the VA system. So I'm in Vision 8 down here in Miami. And then on the website, you can always go to our website, at the University of Miami.
Urology.
Department of Urology, easiest way to find. And then I'll give you the phone number for scheduling, though. I will tell you, if you call, you're not going to get scheduled till like 5 months out. But it's 305-243-6090.
Repeat that one more time.
Yep, 305-243-6090.
All right.
And if you're in the Miami area, I'm not the only person in my department who does testosterone therapy. There are many of us down here. We're all happy to help you out.
Would I safe to say that you are probably one of the experts in at least US as it relates to fertility and testosterone, if somebody has those concerns?
Yep. Yeah, we do a lot here. And we are one of the few centers that also has a female side, right? So, I do on the male side. We also at the university have the reproductive endocrinology group who deals with the female side. The reality is, it's very easy to blame the guy, blame the testosterone, but infertility in particular is a couple's problem.
Yeah.
Right? You don't want to just blame the guy when you're missing potentially something on the female side. So we like to work up patients in tandem, because I'll say this, like, women can have blocked fallopian tubes, and it's how good the sperm is or how much there is. If the egg can't make it out, it doesn't matter, right?
Right.
So we don't want to miss those obvious correctable things.
Thank you for that. And thank you everyone for listening and watching. This was phenomenal as expected, as advertised. Hopefully we got to answer many questions. I mean, we tried to keep it to an hour, not more. So many of the questions that you're interested in leads to testosterone, fertility, testosterone, and the prostate cancer. So for you self-health advocates, hopefully you're more armed to for your next conversation with your urologist and physician, and so that you can ask better questions. So this is Dr. Geo here signing off. Talk to you next time. So long.
We hope you enjoyed this episode. You'll continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.